This topic is on Endo Crown. So, Endo Crowns are a conservative approach in restoring an endodontically treated tooth. So, these are the normal situation where a patient reports to a dental clinic. Sometimes it will be a badly broken down tooth. So, there are some limitations in doing this or restoring the normal functioning of the tooth. So some may be coming with a broken crown. Some will be coming with screw retained crowns. Some will be damaged like root stems. So there are some criteria whereby we can maintain the normal function of the tooth structure. So in such cases, what can we do? So for that, there is a solution in order to maintain and preserve the normal tooth structure. That is how we are dealing with the endocrowns. So coming to a small history on the endocrown, it was in the year 1995, a person called Pieces, he made a novel technique described as monoblock porcelain technique into the in the dental curriculum. So it was in the year 1999 where a person called Bindin and Coleman coined the term endocrown. Like it is an undersea crown characteristic as a full porcelain crown fixed to posterior tooth of an endodontically treated tooth. There was in the year 2008, it was by Landon and Detashi. First clinical endocrine cases was reported and it was been published. So endocrines are made of monoblock concept technique and mostly done in an endodontically treated tooth. This endocrine anchored to the internal portion of the pulp chamber and on the cavity margin. So a macromechanical retention is provided by the pulpal walls and micromechanical retention obtained by use of an adhesive cementation on the remaining tooth structure. The, this endodontic crown offers a strong, aesthetic, and conservative solution for endodontically treated tooth, thereby enhancing the durability, function, and longevity of the tooth structure, thereby reducing the biomechanical complications. So it was an evolution by the first thing you might be heard about the Richmond crown and you have heard about the Nayer's crown because it all almost replicate to this Richmond crown and the Nayer's crown. Something like a modification. So when you think about this endo crown, there should be because I already mentioned you that these endo crowns are done in an endodontically treated tooth structure. So when you prepare an endo crown, there should be a minimum height is required is 2 mm from the occlusal. So this is a small comparison when you notice between a normal crown and also a endo crown. So when you want to prepare a normal crown, actually you need to have a core of this much size. Whereas when you prepare an endo crown, you must have a core of only less compared to the normal crown. This is a small difference between we're thinking about a traditional crown and an in-out crown. So I already in the definition itself, you can mention that the traditional crown is a full coverage restoration that enhances the ender or encases the ender tooth structure. Whereas endo crown is a monolithic restoration that integrates the crown and core in a single unit. So there is a indication that is indications are used both vital and non-vital tooth structure, whereas traditional crown, whereas the endo crown is done only on extensive loss of tooth structure or in cases of endodontically treated tooth structure. Retention, it is relies on mechanical retention from the tooth preparation and sometimes a post or a screw. Yeah, and whereas the endocrown, it is retained by adhesive bonding within the pulp chamber and coronal structure. Coming to the tooth preparation, it requires significant circumferential reduction of the tooth structure. So when you think about the because we need to prepare the all the four sides of the tooth structure, then reduce the crown. Sometimes that reduction also will be more or less. It will be less, thereby we making the tooth more brittle, or it will be reducing the longevity of the restoration. Whereas when you think about this endocrown, it is a conservative preparation, primarily utilizes the pulp chamber for support. Material can be porcelain, metal, zirconia, or porcelain fused to metal, typically made from the lithium disilicate or zirconia, whereas in case of endochrome, because I already mentioned you that it is a monoblock concept where you can use only a single type of material in preparing the crown tooth structure. Either you have to use about either lithium disilicate or zirconia, which bond directly to the tooth structure. Ferrule effect, because when you're doing a crown, it is almost requires a crown. The main purpose of giving a crown is for strength and retention. But when you think about endocrown, there is no need of ferrule in, because most of the studies it shows that when you give a ferrule on the endocrown tooth structure, it is going to fracture that particular structure. So maximum tooth structure should be maintained when you think about this endocrown. Post requirement often requires a post or core if there is insufficient tooth structure. So when it comes to the endocrown, it relies directly to the adhesive bonding, best suited for tooth with the remaining coronal tooth structure that supports a full crown, and mostly in case of endocrown, either molars or premolar with large pulp chambers and minimal remaining coronal tooth structure can be selected for giving an endocrown. Longevity and success rate proven long-term success when proper ferrule effects are maintained. When it comes to endocrown, it will provide a good success rate, especially for molars, but may fail due to debonding in high-stress areas. When it comes to the failure risk of secondary caries, post-core failure or crown debonding can occur in case of traditional crown, whereas in case of endocrown, risk of debonding or fracture under high occlusal force is noticed. Coming to the aesthetic, highly aesthetic, especially when using oil ceramic or porcelain fused to metal option. When it comes to endochrome, excellent aesthetic, especially with lithium disilicate. Occlusal load resistance, when it comes to the traditional crown, it is more resistant to occlusal forces due to full circumferential coverage, whereas the endocrown may be weaker under extreme occlusal loads if bone failures. Procedure complexity, that is, when in traditional crown, it is more complex, require precise tooth preparation and sometimes post-core build-up. Whereas in endocrown, similar procedure as it eliminates the need for a post and core, requires a less preparation when it comes to the endocrown. So we will see some indications. So indications for this endocrowns are: one is short cranial crowns, and in cases endodontically treated molars with significant coronal loss. And it can be an alternative to post and core. And the second one is patient with limited interocclusal width. And the patient requiring high aesthetic demands. When CAD-CAM technology is available, you can think about giving an endocrine techniques. Coming to contraindications, the one thing I already mentioned you that in cases of this bruxism, heavy occlusal load patients, it will be leading to some unwanted occlusal forces, thereby leading to fracture of the tooth structure with the with the endocrine. And because as it is bound directly to the enamel, better if enamel on the tooth structure is very less, it is going to affect the bonding process. In cases where poor oral hygiene or high caries risk, in such cases, this endocrine should be avoided. And the cervical margin is less than 2 mm wide is not, if it is not there, it is contraindicated when you are going to give a endocrine. And when you are going to give a endocrine, the depth of the pulse chamber should be less than 3 mm, because that is an adequate structure required. And if it is not there, an amount of 3 mm, the endocrine, that port, the other portion or the crown, when you eliminate the crown portion, because the retention is not at all achieved. So coming to the advantage of doing an endocrine, because as I already mentioned that this is a conservative preparation, strong adhesive bond is attained, aesthetic because it is given in the enamel, aesthetic and functional restoration, less clinical time, minimally invasive and reduced risk of root perforation. And the disadvantage of using this endocrine is that it is very technique sensitive because enamel is required. Because if it is dentine means it is going to affect the bonding process. Require adequate enamel for bonding when it comes to the endocrine and potential for adhesion loss. So coming to the clinical procedures, so you have to keep in mind when you're going in endocrine. So these are the clinical procedures. That is, the first thing is the tooth preparation should be kept in mind. Then the second one, after preparing, the impression to be made, and it can be either made of the newer techniques called digital impression technique, or you can think about conventional. Better to go ahead with the rubber-based impression material. And the fourth one is the important factor, that is cementation using adhesive bonding. So when it comes to the first one, the preparation part, that is the first one is occlusal reduction. Then the second one is the pulse chamber reduction, and you have to give a side cervical side work. That's the important thing you have to keep in mind when you think about doing an endocrine, because that is the basis for a foundation of a restoration. And the third one is the staircase effect, which is required when you prepare an endocrine. So first one is the tooth reduction, that is normal occlusal reduction, that is of 2 to 3 mm is required when you are thinking about doing an endocrine. These 2 mm guide grooves are given by using a cylindrical flattened or tapered diamond bud. Reduce the occlusal surface along the long axis of the tooth that should be parallel to the occlusal plane, that is called as bud joint. And the wheel diamond bar is used to give a cervical sidewalk because it is something like a platform. See, when you are seeing the occlusal aspect clearly, you can notice a cervical sidewalk. So that is how or the cervical margin is prepared, where on the above only that endocrine will sit in that position. And that particular preparation is done by using a wheel diamond burr. Then the endocrine occlusal thickness, that also the important factor you have to keep in mind, that it should have a minimum of 5 to 7 mm. And the anchorage of the endocrine is into the pulsion or at the emergence of the root canal. Endochord length is the depth of the restoration in the pulse chamber should be minimum of 3 to 4. Because in the contraindication, I already mentioned you that when that endochord length or the core of the pulse chamber is less than 3 or more less than 3 mm, it will be very difficult to give an endocrine. So for giving an endocrine, the length should be at least 3 to 4 mm. And the corona radicular preparation, or it is also called a monolithic conservative restorative procedure. In areas of aesthetic requirement, a slope of not more than 60 degrees should be given between the different and the different cervical levels. So that is called, I already mentioned that is called that staircase effect. So the cervical sidewalk, I already mentioned you in the beginning that it is the foundation of the restoration. The objective to accomplish a wide, uniform, steady surface which is more resistant to compressive stresses. So now we have got an idea that the beginning picture which I have showed you and the picture which I have shown, that is a comparison between the normal traditional crowns and also with the normal endo crowns. So when you think about giving an axle reduction, because you have to do an axle reduction, right? For that, you have to use a cylindrical flattened tapered fisher part that is used to prepare the pulse chamber. Because the core part will be going inside the pulse chamber, which is having an adequate depth of 3 to 4 mm. So, one thing is that remove the undermined enamel and ensure a smooth axial wall. Provide a 7-degree total occlusal convergence for better retention. Axial wall should be smooth, blend into the pulse chamber without any internal undercuts for the proper placement of the endo crowns. So I will just show you some pictures where you can use the endocrine in a day-to-day practices. So when it comes to the earlier picture was shown, so it's a class 1 cavity. So when you think about doing a class 2 cavity, you can, instead of directly extending the endocrine, the preparation in the proximal area with by using a composite resin wall was built up in the lowest marginal ridges. So once the proximal wall is re-established, the tooth preparation was done using the same procedure what I have mentioned you in preparing an endocrine. So in a class 2 restoration, just imagine this wall is broken and you have to build up with a strong adhesive material with a composite or in a good core build-up material, and after that you can just prepare the same cavity preparation by giving a like I already mentioned you have to give a staircase effect and you are giving a good platform when you think about doing an endocrine in a class 2 structure. So the occlusal reduction, it should be a 2 mm. Axial wall depth or the pulse chamber should be adequate of 3 to 5 mm. And the circumferential margin should be 1 to 2 mm when you are giving an endocrown. So so why? Because why diamond bars are used when you are going to give it with the endochrome. Because you should not use a carbide bar. That is the important thing you have to keep in mind when you are going to do a endochrome. You have to only use diamond burrs. So a rough and denting surface created by diamond burrs provide better micromechanical rotation for adhesive bonding. Because this endochrome more or less rely on the adhesive cementation. Unlike carbide burrs that create a chipping on the two structures, thereby reducing the bonding. Whereas when you think about giving a diamond burr, it is going to produce a smooth surface on the prepared two structure. So impression making, that is the important part. You can think about you by using a rubber based impression material, or you can think about by using a digital impression material. That is the reliable and more accurate one when you think about doing an endo crown procedure. So material used for preparing endocrowns are lithium disilicate, zirconia, composite resin, hybrid ceramic, feldspathic ceramic, resin nanoceramic, and polyether ketone. Because this feldspathic ceramic and the peat are the recently introduced material. So when why you are not using this metal for endochrome? That is, it is lacks adhesive bonding, poor retention inside the pulp chamber, and difficulty for the card-cam fabrication. And I already mentioned you that the aesthetic concern is the most important factor. And when you think about when you are giving an endochrome, there is a risk of root fracture, and the last one is the marginal integrity. So, all because already we are giving a either lithium disilicate, or you are going to give an Emax crown. So for that, the retention should be provided in the enamel area. So the resin cements are more adequate for cementation of endocrowns. So apply a 5 percentage hydrofluoric acid for 20 seconds, because this is the bonding protocol we have to keep in mind when you think about cementing and lithium disilicate endocrowns. So you have to apply a 5% hydrofluoric acid for 20 seconds, rinse dry, and after that you have to apply a sealant coupling agent for 1 minute, and it should be air dry. So for zirconia, you have to, because I already mentioned it, you can either prepare with zirconia or you can prepare with lithium disilicate. So when you want to bond with the zirconia, you can use what you can use. You can air abrasion is mandatory with by using a 50 microns aluminum oxide particle at 7 pounds per square inch. Apply on the adhesion promoting surface of the two structure, and after that you can apply MDP. Then after that you have to dry the crown portion. So this is a small uh, 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 a small this short video showing how you are going to bond bond the endocrine on the two structure. So each step you have to keep in mind when you are bonding the endocrine on the two structure, because I already mentioned you that it is very technique sensitive. This is the preparation part. This is a platform you are going to make when you are doing an endochrome. After that, you are preparing the pulpal area, pulp chamber area. This is the cervical sidewalk you are going to give for staircase effect. Then after that, you are going to take an impression. Either you can use rubber-based impression material, or you can give a digital impression technique. And this is how the endocrowns are prepared from the lab. After that, you are going to cement on the two structure. When it bonds to the enamel, the main problem is that when you want to remove, it will be very difficult. So coming to the conclusion part, the lithium disilicate endochrines exhibit high fracture strength and reliable, whereas zirconia, despite its high strength, tends to fail more catastrophically, and indirect composite show lower overall fracture resistance. So these are all the there are some articles showing the survival of endocrines. So these are all some of the reference which I have gone through in preparation of these endocrines. So coming to the conclusion is that the endocrines are an innovative and conservative approach for restoring endodontically treated teeth with extensive loss of tooth structure. They offer a post-free adhesive bond alternative to traditional post and core restoration, utilizing the pulp chamber for retention rather than extending into the root canal. So that is the important thing. The last one is the important thing, that is it utilize the pulp chamber for the retention. So thank you one and all.